Mood disorder, major depressive disorder. What is a mood disorder or episode? Simply expressed, a mood episode refers to any period of time when a patient feels abnormally happy or sad. Most mood disorder patients will have one or more of these four types of episodes: major depressive, manic, mixed, and hypomanic. For this project, we will be explaining the major depressive mood disorder. Also, a mood episode refers to any period of time when a patient feels abnormally happy or sad. Here are the diagnostics for major depressive disorder. Mood. For most of nearly every day, the patient reports depressed mood or appears depressed to others. Interests. Interest or pleasure is markedly decreased in nearly all activities. Eating and weight. Although the patient is not dieting, there is a marked loss or gain of weight, or appetite is markedly decreased or increased nearly every day. Sleep. Nearly every day the patient sleeps excessively or not enough. Observable psychomotor activity. Nearly every day others can see that the patient's activity is sped up or slowed down. Finally, fatigue. Nearly every day there is tiredness or energy.
Examples of this disorder. Story number 1. Although I desperately want you to understand, I know most people, even mental health professionals, cannot. I can't just snap out of it no more than someone can snap out of heart disease. Thinking positively will not do it either. Do you not get that I am in serious pain every day, all the time? No, I can't just get better. Yes, it is that bad, and no, I am not feeling sorry for myself. No, I am not trying to escape my responsibilities. I want to work and take care of my household and personal tasks. I am not doing this to be treated special, and no, I'm not over it yet. I've heard those comments and thought about them and tried some and failed. I feel like I am a failure. I know that you meant well, but you are not helpful. I just feel like retreating more. My feelings are hurt.
History and background. Depression was initially called melancholia and has always been a health problem for human beings. The earliest accounts of melancholia appeared in ancient Mesopotamian texts in the 2nd millennium BC. At this time, all mental illnesses were attributed to demonic possession and were attended to by priests. In contrast, a separate class of physicians treated physical injuries, not conditions like depression. The first historical understanding of depression was thus that depression was a spiritual or mental illness rather than a physical one. People that defined depression include ancient Greeks and Romans, Hippocrates, and Greek physicians. They suggested that personality traits and mental illnesses were related to balanced or imbalanced bodily fluids called humors. The term major depressive disorder was introduced by a group of U.S. clinicians in the mid-1970s as a part of proposals for diagnostic criteria based on the patterns of symptoms. Controversies in treatment. In electroconvulsive therapy, patients are placed under general anesthesia and given muscle relaxers before an electric pulse is delivered through electrodes on one or both sides of the head. There are many debates on the pros and cons of this type of treatment. We always weigh out the risks and benefits of doing ECT as well as the risks of not doing ECT, explains Martin Furman, MD. Most patients who turn to ECT have depression with physical manifestations such as an inability to get out of bed for days at a time to eat or drink. If you're so depressed that you aren't getting enough fluids, you run the risk of even more serious health complications. However, a possible side effect of this form of treatment is short-term memory loss.
Epidemiology, general prevalence. As you can see from this graph, about 16.5% of the U.S. adult population have experienced depression in their lifetimes, and 6.7% of adults experience it within a year. 30.4% of all these cases are classified as severe. Some things to keep in mind are that during their lifetime, women are 70% more likely to experience depression than men, and blacks are 40% less likely than whites to experience depression as well. In general, young adults are far more likely to have depression than those ages 60 and up. Gender differences. Like I said before, women are more likely to have depression than men. This trend hasn't really changed over the years, but overall depression appears to have decreased starting in 2008, which is pretty good. Subgroups. This graph displays the prevalence of depression among different ethnicities, genders, and years of education. Those with the most years of education tend to have the lowest rates of depression, with the exception of Mexican males. Interestingly enough, depression rates are extremely high among those with 8 years of education, or in other words, middle schoolers, with the exception of black and Mexican males. In fact, Both Black and Mexican males have some of the lowest rates of depression across the board, never seeming to go beyond a little over 8%. Etiology. The specific cause of major depressive disorder is not known. Like most psychiatric disorders, depression tends to be multifactorial, involving both genetic and environmental factors. Genetic factors. Genes play a large role in whether or not people experience depression. For example, first-degree relatives of depressed individuals are about 3 times as likely to develop depression as the general population. And evidence from twin studies suggests that major depression has a concordance of 40 to 50%. However, depression can occur in people without family histories of depression as well. Although multiple genes are likely to influence susceptibility to depression, those involved in the serotonin system are a key focus of investigation, especially because many antidepressant medications work by influencing serotonin. Individuals with a family history of affective disorders, panic disorders, or alcohol dependence can carry a higher risk for major depressive disorder. Environmental factors. Although major depressive disorder can arise without any precipitating stressors, stress and interpersonal losses certainly increase risk. For example, loss of a parent before the age of 10 years increases the risk of having later depression. Chronic pain, medical illnesses, and psychosocial stress can also play a role in major depressive disorder. Older adults may find medical illnesses psychologically distressing, and these illnesses may lead to increased disability, decreased independence, and disruption of social networks, finally resulting in depression. Or in other words, something similar to having a midlife crisis. Chronic aversive symptoms, such as pain associated with chronic medical illnesses, may disrupt sleep and other biorhythms, leading to depression. Other psychosocial factors for depression in late life include the following: impaired social supports, caregiver burden, loneliness, bereavement, and negative life events.
Treatment number 1. Depression medicine. Antidepressants, sometimes in combination with psychotherapy, are often the first treatment people get for depression. Selective serotonin reuptake inhibitors, or SSRIs, were launched in the mid to late 1980s. This generation of antidepressants is now the most common class used for depression. People with depression have lower levels of serotonin. SSRIs block the reuptake of serotonin, meaning more serotonin than usual remains in the synaptic space between the two nerves. This eases the symptoms of depression resulting from the low levels of serotonin. Examples of medicine that help prevent reuptake of serotonin include Celax, Lexapro, Paxil, Prozac, and Zoloft. Effectiveness. A recent report published in the Journal of American Medical Association shows that the drugs work best for very severe cases of depression and have little to no benefit over placebos in less serious cases. A major 2006 U.S. government study showed that fewer than 50% of people become symptom-free on antidepressants, even after trying 2 different medications. Furthermore, many people who do respond to medication soon slip back into depression despite sticking with drug treatment. Treatment number 2. Talk therapy. Talk therapy is counseling to talk about your feelings and thoughts to help you learn how to deal with them. Psychodynamic therapy focuses on recognizing and addressing defense mechanisms as well as analyzing emotion. Types of talk therapy include cognitive behavioral therapy, group therapy, and psychoanalysis. Psychoanalysis is used in classes when people have an internalized anger and other intrapsychic conflicts according to this, which are caused by unresolved experience from loss from childhood. Effectiveness. Early in 2010, a report published in the American Psychologist Review the data from existing studies of psychodynamic therapy and depression. The author concluded that not only did the data show that psychodynamic therapy was at least as effective as other evidence-based therapies, but also the benefits of psychodynamic therapy appeared to be longer lasting. Psychodynamic therapy also involves the exploration of a patient's fantasy life. Because the patient is encouraged to speak freely, he or she is able to explore whatever is on his or her mind. The end.